Hi friends, welcome to another short, crisp, high yield video of the SPOTTERZ series, your ultimate revision companion for NEET-PG 2024. Now, if you look at this KUB, kidney, ureter, bladder region radiograph, this is how the shadow of the normal kidney looks like. Look at the right side though. So the left kidney looks normal. Look at the right side. Something is wrong with it. Can you see the density of the kidney is uniformly increased, as if there is uniform, amorphous, dense calcification involving the right kidney. Well, this uniform, dense, amorphous calcification involving the renal parenchyma is a feature of a particular renal infection, right? And what infection is it? Yes, so this type of appearance, right, of the kidney is what is called as, yes, this is called as the putty kidney, right? And this feature, putty kidney, is a feature of what infection? It is a feature of renal tuberculosis. So that is what we are going to revise quickly, because this was a recent NEET pattern question. So if the examiner gives you a history of a patient coming with history of pulmonary COX, now presents with low grade fever, and the clincher for the diagnosis of renal TB, remember, is sterile pyuria. When you read these terms in your exam, remember the examiner is helping you. The examiner is pointing towards a diagnosis of sterile pyuria, pus cells within the urine. But if you do a urine culture, there will be no microbial growth, because the infective causative agent is what? The infective causative agent is Mycobacterium TB, which would not grow on routine culture media, right? So then the suspected diagnosis based on this history is going to be tuberculosis infection. So what is the overall or best investigation or investigation of choice? It is going to be a contrast enhanced CT. There is a star mark that I am going to put here. Remember that star mark says conditions apply. What are those conditions? We are going to discuss that. When you do a CT, right, what is the most common finding that you find on CT, right? So the most common finding seen in renal TB in cases of when you do a CT scan is nothing but renal parenchymal calcification, right? So this is the most common finding which is usually seen when you do a CT. The earliest renal finding in tuberculosis is an erosion involving the wall of the calyx. So this calyx is now called as what is called as the moth-eaten calyx, and because the earliest finding in renal TB is at the level of the calyx, right, therefore if we have to diagnose renal TB earliest, right, in a very early stage, we need a modality, right, which will be able to show us the anatomic details of the calyces. And therefore if they ask you a question, what is the investigation of choice for the earliest diagnosis of renal TB, then remember the answer is going to be intravenous urography. That is because IVU is going to show you this moth-eaten calyx appearance. We are going to see that as we go ahead. There are a lot of appearances, right, will be seen in cases of renal TB. You start with the kidney, the early stages. You will see the earliest finding that we have just discussed. It is called as moth-eaten calyx. That is an irregular wall of the calyx. You will see hydronephrosis because obstruction, dilatation of the calyces is seen. You will see extracalyceal accumulation of contrast. That is because of the cavity which forms within the renal parenchyma, an empty space is formed, contrast will accumulate there. So extracalyceal contrast accumulation, right, when we do a IVU. Right, in late stages, as the renal function declines, there is calcification of the kidneys. This is the image that we saw when we started this discussion. This is what is called as putty kidney. There is a term that I want you to know. What the body does is body shuts off the blood supply to a non-functioning kidney. This phenomenon is what is called as the autonephrectomy, right? So these are all the renal findings that you could see. Now if you go to the ureter, what happens basically is because of the fibrosis, this pelvis is sort of pulled up. This is what is called as the hiked up renal pelvis. There could be fibrosis along the wall of the ureter, so the ureter gets kinked. So this is called as Kerr's kink. The ureter becomes like a lead pipe, right, becomes rigid, right, it becomes fibrous. So this is called as a lead pipe ureter, right? You do a cystoscopy, you see that the ureteric orifices are prominently seen, so this is like called as the golf hole ureteric orifices, right? Ultimately the bladder wall also gets inflamed, gets calcified, it becomes a very small capacity fibrosed bladder, that is what is called as the thimble urinary bladder. So this is a spectrum of findings, right, that your examiner might potentially ask you about renal TB, genital urinary tract TB. So here if you look at the calyces, right, if you see this particular calyx, its shape looks more or less uniform, but see this calyx, the shape is so irregular as if there is an erosion there. If you look at this calyx, again the shape is irregular. This is what is called as the moth-eaten calyx. If we zoom it up now, see here again the same finding is better seen. You can see the calyx, nice shape. Look at this calyx, this is called as the moth-eaten calyx, the earliest finding which is seen in renal TB at the level of the calyx. In the late stages, the renal parenchyma gets diffusely densely calcified. This is what is called as putty kidney, right? And the bladder also gets fibrosed. The bladder capacity becomes very small. This is what is called as thimble bladder. So these are important imaging features I want you to know. Each of these is a potential MCQ, could be asked in the exam. Now another infection, especially involving the urinary bladder, is schistosomiasis or bilharziasis. Now how to distinguish between the tuberculosis infection and schistosomiasis? In tuberculosis, the entire kidney, ureter and bladder, the entire system is affected, involved, whereas in schistosomiasis it is only the urinary bladder which is involved, not the kidneys and the ureters. The site of calcification in TB can again be is usually in the kidneys, right? We saw putty kidney, right? Whereas in schistosomiasis, the site of calcification, because it involves only the urinary bladder, it is the wall of the urinary bladder. Does tuberculosis predispose to any cancer? The answer is no, but schistosomiasis, because of the chronic inflammation that it induces in the urinary bladder, it predisposes to the development of squamous cell carcinoma of the urinary bladder. So these are few important clinical differentials between tuberculosis and schistosomiasis. What happens in schistosomiasis is, because the parasite lays its eggs along the wall of the urinary bladder, there is chronic inflammation, there is fibrosis and calcification of the urinary bladder wall. So if you see a narrow contracted bladder, rigid ureters. This is a patient presenting with low grade fever, sterile pyuria. This is thimble bladder, which is seen in tuberculosis infection. Whereas here a patient presents with hematuria and urinary frequency. Look at the urinary bladder on this CT scan image. This density that you see in the wall of the urinary bladder is nothing but calcification of the urinary bladder. This appearance is called as the fetal skull like appearance of the urinary bladder. This is a feature of schistosomiasis, right? So that is how the imaging findings are going to be different, right? So now quickly let us revise a few renal infections, because before we conclude with this particular short video. So a patient presents with fever, turbid urine, pulse, tachycardia, hypotension, right? Total leukocyte count is elevated. The patient is diabetic, so diabetes mellitus. What you can see in the region of the kidney is a black mottled dirty appearance. What looks black on X-ray? It is air. So this is infection of the kidney, pyelonephritis. Infection is being caused by air forming microbes. So this type of specific infection is what is called as emphysematous pyelonephritis. You see air in the region of any organ, say gallbladder, it is emphysematous cholecystitis, urinary bladder, emphysematous cystitis, kidney, emphysematous pyelonephritis, usually seen in immunocompromised patients, mainly diabetics. Another specific infection is one which is caused by chronic calculus disease and a superimposed Proteus or E. coli infection, prolonged low grade infection. What happens is that in the center you see calculus being impacted there, and then you see fluid filled cystic spaces around it, right? You get a cross section over here. This area looks cheesy or yellow. Cheesy yellow means xantho. So this is what is called as xanthogranulomatous pyelonephritis, and this appearance where you see a central calculus surrounded by fluid filled spaces looks like the paw of a bear. So this is what is called as the bare paw appearance of xanthogranulomatous pyelonephritis. So we have studied, renal TB in very quick, concise, crisp manner, and we have quickly extended the discussion to discuss emphysematous air forming, right, microbial infection, emphysematous pyelonephritis, chronic low grade infection, yellow appearance on gross histopathology, right, is xanthogranulomatous pyelonephritis. Well friends, doing the best at this moment puts you in the best place for the next moment. These small topics that we are revising are extremely high yield topics. They are going to give you a excellent strike rate in your upcoming exam, so that you will be able to get through this exam with flying colors. Keep working hard. All the best.